handout today. So I'm going to, as I go through, I'm going to point out some areas where there's objectives. I didn't write them as specific as you requested. At the end of the lecture today, if you want more specific than what I have given, then I will do that. But there are big sections where I'm going to tell you, you must know all of this. And here's the reason why. The second years in their feedback have been, to me, is that on the end of rotation exams, psych is all about side effects. So we're going to talk mostly about adverse reactions and how to recognize them, how to treat them. And the test will predominantly be geared that way. And we'll do the same on Thursday when we talk about the antipsychotics. So the handout is very thick. It's about 35 pages, but there's lots of pictures in there as well. And lots of details on the adverse reactions, more so than we have done with probably any other set of drugs to this point. Mostly because of what comes next year. And because it's important. People on antidepressants, antipsychotics, any of the psychotropics, the side effect profile is high. And you will deal with that a lot. Even in diabetes, we saw a lot of depression. We were always having to deal with the effects of the drug. You will see, I feel like every time I stand up here, I'll go, you're going to see this a lot. But you will. If you are in a primary care or if you're dealing with people that have long-term chronic diseases, depression is a very common comorbidity. And you'll see that more and more the guidelines that are coming out are recommending that in those different disease states you screen people for depression. Diabetes, it's become now a standard of care that you would screen. As I was reading through some pregnancy stuff the last few days, it's now a recommendation of care for pregnancy and also postpartum is to screen women for depression. You'll see as we go through, and I talk about the different depression inventory scales, they've even developed one for men whose partners are pregnant. So the higher the incidence of maternal depression, the higher the incidence of maternal depression as well, pre and post pregnancy. So, okay, so tell me what you've learned about depression. I told you to write those little things down and just impress me. Okay, so what have you learned?
It's on a spectrum.
It's a spectrum, so what do you, tell me a little bit more about that.
So you can have people where it's completely debilitating, and then you can have people where it mildly affects their life.
Okay, very good. So I continue.
40% of the time it leads to some form of bipolar disorder.
40% of the time it leads to bipolar disorder? Really? Is that right? Wow. I'm looking back at him. I didn't know that. That's an impressive stat. What else?
People often don't think they need treatment.
Pardon?
People often that have depression don't often think they need treatment.
Don't get treatment?
Or don't, yeah.
Yeah, it flies under the radar a lot. I saw lots of mild to moderate depression with diabetes, but I worked with a fairly low resource population, so that added to it. But we would sometimes see very severe depression walk in. And the more you know patients, when you have long-term relationships with them, sometimes you'll pick up that change in behavior, whereas you wouldn't if it's more of a more acute situation. What else?
There's the major depressive disorder versus the persistent. And so like the persistent being 2 years with the lesser side effects. The major being a shorter term but more severe.
Okay. Very good. What else?
It's a woman. It's more like women get affected than men.
So females affected more than men. Okay.
2 weeks is for the major depressive symptoms, and then 2 years for dysthymia, which is the more persistent one.
Okay. So 2 weeks, and then what about symptomatology? So there's a duration aspect and there's a symptom aspect.
There's at least 5 associated symptoms.
Okay, very good. He's taught you well. That's good. Okay. All right. Anything else? All right.
The symptoms are usually different in younger versus older people.
What was the other term you used?
The symptoms can be different in younger people.
Yes,
versus
they
older
surely
people.
can. Sure can. Okay, so you, the very first off the bat is a definition of unipolar major depression, which we're going to talk about first, and we'll talk about bipolar at the end, and lithium. So we talked about duration, symptomatology, so 5 or more of the following: depressed mood, anhedonia, which means what? Enjoying, so and meaning the inability or lack of, so hedonism is, you know, eat, drink, be merry. Okay, so these folks, they don't take joy or enjoyment out of the things they used to, is one way to look at it. Insomnia or hypersomnia, so you see a change in sleeping habits, that's the biggest thing. So they may wake up early, or they may wake up and not be able to go back to sleep. They can go to sleep, but they can't stay asleep. Low energy, poor concentration, more vegetative symptoms, so they may not appear to take care of themselves. A woman may not put on makeup, comb her hair, may not change their clothes, so they may wear the same thing, sleep in it, stay in it, so it's a lack of care. They become more, their affective state is reduced. So they may not respond to you in a more, a way that you would expect. So a flat affect can go along with that. Poor concentrations, thoughts of worthlessness and guilt, recurrent thoughts about death or suicide, how they would do that, or even contemplate doing it. Okay, so at least one of the symptoms must be a depressed mood or anhedonia. The next table I'm not going to question you about or assess you on, but it gives you a list of drugs that are implicated in drug-induced depression. So it can not only be situational or just part of their biochemical makeup, but it could also be a drug that is aggravating or worsening a situation. In terms of you'll see in the different treatment outcome studies, they'll use the term response and remission. Have you all talked about those terms? Okay, so there are rating scales, and I'll show you 2 of them a little bit further into the handout. But a response is an improvement 50% or but less than the threshold for remission. So improvement means on the rating scale that's used, they improve by 50% or more. Remission is a depression rating score less than or equal to a specific cutoff. So we'll see on the, I'm not going to show you the Hamilton, but the Beck is one that's commonly used. The Montgomery-Asberg is another. There's about 4, the PHQ-9, Hamilton, Beck, and the Montgomery-Asberg. Are all rating scales, and they all have divisions or a numeric number that will tell you in terms of symptomatology the severity, and you can use these as part of your diagnostic workup and process, and also you can use it to determine their response to treatment. The goal of therapy is to improve their symptomatology and return them to their functioning to normal or to baseline. Okay, next page, page 3. So I've taken that very first bit of information and put it into a chart. So in terms of approach to treatment, there's an acute phase, continuation phase, and maintenance phase. So the acute phase is the first 6 to 12 weeks. This is an important one to advise patients about because we cannot turn their symptoms around quickly. Some of the drugs have quicker onset, some of them are a little bit slow, but to help people to understand that it may take 3 to 4 weeks to see some improvement, and then it may take as long as 6 to 12 weeks to see improvement enough to determine response in order to know whether to stay with that drug or move to a different one. The goal there is remission. In the continuation phase, which can be a very long phase, 4 to 9 months. So this is not a quick treatment. Here we want to eliminate any residual symptoms and prevent relapse. Some patients will need therapy for a long period of time, and so considering up to 1 to 3 years to prevent recurrences should be considered. So who is at greatest risk for recurrence? Well, people who have had multiple episodes are more likely to have a recurrence. Lifelong maintenance therapy is not unreasonable. I give you a couple of circumstances to consider that. One is young patients who have had multiple episodes, at least 2 or more. Or any person of any age who has had 3 or more should be considered for lifelong maintenance. Patient education is really important. People will do better with therapy if you tell them what to expect. So giving them those timelines, here's when you should, start to feel better. And here may be what you would see, painting the picture. You may sleep better. Your appetite may come back. You may regain weight. You may start to enjoy the things that you once didn't enjoy but do not enjoy now. So painting that picture for them and having your assessments and follow-ups timed at those are also important. Have you talked about risk of suicide in early treatment? Is that, have you come to, okay, so what have you learned about that? Is there a difference in suicide risk? Is that this one?
It's me,
Oh, okay.
I just went to mute.
Okay. So what have you learned about suicide risk early in when you start an antidepressant?
It's higher.
It's higher. Why is that? Okay, so when a person presents to you and they are depressed, that vegetative slowing down of processes is that they just don't have the energy. They may have considered suicide, but they don't have the energy to carry it out. So the risk in those 2 to 4 weeks or 6 weeks after you start is they may then have the energy to carry out a plan that they have. So that's why it's important to have monitoring during that time to assess that and assess the risk. So that's early on when you start treatment. Of course, it'll always be part of your assessment of folks that have major depression. Okay, so initiating therapy, let's just look at what the literature tells us. I think this is important background, but it isn't necessarily what I'm going to focus in my assessments on. So in terms of initial therapy, looking at whether psychotherapy or pharmacotherapy or one or both, they are all fairly, can all be used. So antidepressants and psychotherapy can be used alone. Monotherapy, they're effective. In terms of medication choice based on clinical trial, there's no superiority. So this will be one of those diseases where any drug is appropriate to start with. We do have some that people prefer over others. SSRIs are preferred mostly because of their side effect profile. And they are a very low risk for overdose situations. So there isn't any head-to-head trials to tell us start here, and then go there, like you see with hypertension. It's very well laid out. With diabetes, we started to see some of that, but there's not a really great algorithm to say what to do. So some of it will be matching it up based on patients' diseases, conditions, their wishes. Side effect profile has to be taken into account because they are so common. There's also no superiority in prevention. So when you get into that maintenance phase or you're preventing a situation, there's no drug group that's going to be better than another. Equivalent efficacy. And it says comparable doses. So if you are using a drug to the recommended amounts based on clinical trials, and you're using another drug in a similar fashion, what they're saying is there is no advantage of one over the other in terms of its efficacy. Now, side effects would be a whole different topic, or a whole nother different consideration. They're also comparable within a class. So of the SSRIs, any of them are effective. They will have different side effect profiles though. And we'll see that if people don't respond to one set of SSRIs in a class, we can go to a different drug within the same class. So we've been in different places where we've seen that if you have one drug and you've tried it and it didn't work, there's no sense to go to same one. ACE inhibitors tend to be that way. If you use one ACE inhibitor, it doesn't work, it doesn't really matter if you go to another one. Here we're going to see drugs that in a class they are so, they have such variety that it is a benefit for the patient to try another one even in the same class. I'll give you some examples as we go through. Okay, on page 4, the top of the page. So in initiating, therapy is empiric. So what's that mean? We use antibiotics empirically. What does that mean? Best guess. So it's based on fact, and you're going based on experience, perhaps, or here's what the literature says, but it's a best guess. So the SSRIs have become the preferred for a number of years now. Again, more benign side effect profile. When we go through their side effect profile, you're going, this is benign? Because they have a lot of side effects. But they also have the least risk of lethal effects in an overdose situation. I told you before that we worked in the emergency room in Austin, Texas on the weekends, and we saw multiple tricyclic and antidepressant overdoses all the time. Very lethal drug if you take it in a high enough doses. So these were a big improvement in terms of safety for patients. Alternatives to SSRIs for initial treatment can be the SRNIs, the serotonin norepinephrine reuptake inhibitors, or the atypical antidepressants. We'll go through those, or the serotonin modulators. They are not quite as effective. They have a lot of side effects that make it more difficult for people to use, so they're not used quite as often. The tricyclic antidepressants and the monoamine oxidase inhibitors are effective, but their side effect profile is difficult. The monoamine oxidase inhibitors have lots of drug interactions and dietary interactions, so they're not used as often. Failure to respond to one class means you can go to another. Failure to respond to a drug in a class does not preclude you from trying others in that class. So those are kind of the principles that are going to guide us. So it makes it difficult to say which drug is right for a person unless you're looking at more of the side effects or the history of what the person has taken before and whether they've responded. And I will typically do that when a patient comes in. What have you taken before? What's your response been like? Sometimes they've lost insurance coverage, can't afford it. They couldn't afford the co-pays, they stopped it. They started feeling better, they stopped it. So sometimes that history of what have you done well on before can help guide you as a restart. Initial dosing, we're going to start low, like with most drugs, and titrate it to effect, usually within a dosing range. For some of these drugs, it's going to be really important that we stay within a tight range because of the side effects may go up quite a bit, particularly in the elderly. So when we get to the SSRIs and the SNRIs, they are on the Beers, they're part of the Beers criteria. So what does that mean? If I say they're on the Beers list, what does that mean?
Should avoid them and
Should avoid them in whom? And elderly is defined by what? By what age?
over 65.
65 and older. So those two classes of drugs, which are kind of your big go-tos, are part of the Beers criteria. So potentially dangerous to patients that are 65 and older. Which is a problem because we're going to see a lot of depression in the elderly. Okay, response to treatment and duration. So with most drugs, they will begin to have some kind of response within 1 to 2 weeks. So, but it's a gradual increase. So that would be early response. Those who respond early have a greater remission potential. Adequate trial, duration of an adequate trial. So you need to treat at least 6 to 12 weeks before you decide whether the drug is going to work or not. Again, letting the patients know in advance will be very helpful. For those who show little improvement, that would be in using your depression scales, less than 25% improvement after 4 to 6 weeks, then that may be a time to go ahead and make a change if there has not been an improvement. Questions about that? Very general. Okay, let's look at the depression rating scales. I've only pulled 2. Well, I pulled 2. The PHQ-9 and the Beck Depression Inventory. So if you look on the next page, page 6, you see the PHQ-9. I like this scale a lot for screening. You'll see the 9 questions there, and they have, for each of the questions, there is the ability for 4 responses. One is not at all, several days a week, more than half the days in a week, and then almost every day. So it gives them 4 types of responses. So their interest in doing things, their feelings, their sleep habits, their energy levels, their appetite, how they feel about themselves, their concentration ability, moving or speaking slowly so that other people have noticed or commented, and thoughts that they would be better off dead or in hurting themselves in some way. So it's subjective. The patient is going to tell you how they feel. There's a numeric value assigned to these, and then this particular instrument comes with a very good 5-page guide, and based on the symptomatology, it will tell you the level of depression, and it gives you a guide as to what should be done. So I think it's very good for people who are not, psych is not your orientation or what your training is mostly in. It gives you a really good guide as to what to do next. And I put the scale down here at the bottom just so you can kind of see how they score it. Another is the PHQ-2. If you look in this little box down on the bottom right, they've taken 2 of the questions out of the larger scale, and they are, over the past 2 weeks, have you been bothered by little interest or pleasure in doing things, or feeling down, depressed, or hopeless? The way we use this at family medicine is they taught the MAs and nurses that did the patient intake to ask these. So they asked them on every patient they saw. So they used it as a very quick screen that they could then alert the physician or the provider, whoever was going to see them, who could then administer a bigger scale or could ask questions to try and discern if this was something that needed to be addressed. So I like that approach. I thought that worked well in our system. Anybody else have experience with this where you worked? Did you do depression screening at all? Travis, hold on.
Well, I didn't actually do it, but I know the providers did them every so often. I just didn't know how often they did them, but I know they did.
Okay.
For the elderly folks, so the geriatrics clinic, so.
Geriatrics clinic, okay.
I worked in OU's health research lab, and they use this Beck depression on almost all of their people before they would do the research on them.
Okay, very good.
We just had a generalized questionnaire in our EMR system in a pediatrician's office. And so like, if they're already diagnosed with like ADD, ADHD, it was just like a full neuro kind of depression screen that the inmates would go through with them, the providers.
Okay, very good. Lindsay, did y'all do any, who else? Sam?
We're into pain management, so we did pain questionnaires and depression screening usually once a month. Sometimes I think depression was every other month or something like that.
Did you use one of these standardized
I
scales?
think it was the PHQ-9, because it was like something printed out that we did.
Okay, okay. So this one is free to download. You can use it, you don't have to, it doesn't require a license, doesn't require you to get permission, you don't have to pay a fee for it. Some of the others you do, like with the VEC inventory, you do have to be licensed, you do have to pay a fee to use it. I don't know if there's any training that goes along with it, but that's why it's probably, even though it's very well respected, it's not as used as widespread in primary care. You'll see the PHQ more often. The other one, the Montgomery, Asperg, and Hamilton, those are much more, probably used in more of a psych facility, more in research. You'll see in a lot of the studies that report antidepressant therapy, they will have used the Hamilton scale. If you look in the back, it's very similar. It gives people statements and then allows them to rate it from 0 to 3. So about their feelings, how they feel about the future, their feelings of failure, satisfaction, guilt, punishment, disappointment. So the similar themes, just different ways of asking it, different scale for the patients to respond. And then again, a severity scale is a part of that. So if you're going to be involved in depression or prescribing antidepressants, you would want to use some type of scale to monitor and to document, here's their symptoms, because when they come back, that's how you're going to determine response. There really isn't any more than, there's nothing you can draw, there's nothing you can monitor in terms of lab. It's going to be on how the patient perceives a response. Maybe a spouse is involved or a partner, but you're going to be relying on a lot of that. So documenting those is going to be important for you for your assessment. If you look at page 5, other instruments that I found for special populations, for pregnant and postpartum, it's a postpartum type of language, but from my reading, it looks like they use it as prepartum also. So it's called the 10-item Edinburgh postnatal depression scale. I read where there are ones for also men who are going to become fathers. I could not find the scale though, but I found it alluded to in some of my readings. And for older adults, there is a Cornell scale for depression and dementia. Do you know if they use that, Travis? Does that look familiar?
I'm sorry, can you repeat
The
that?
Cornell scale?
I have no idea.
Okay.
We use PHQ-9, so.
Okay. All right. And I can post those, I'll post the entirety of that PHQ-9 for you on the D2O.
If it helps, I believe we might already have a copy of that on D2O.
Oh, you do? Okay, great. All right.
I'll put up the back and the PHQ-9.
Oh, you did? Okay, so y'all already talked about that?
Just a little bit, I didn't get into the details.
Okay,
I guess I
great.
need to look at it.
Okay. So on page 8, here are the antidepressant medication classes. There's quite a few. The SSRIs, the SNRIs, the atypical antidepressants, the serotonin modulators, The serotonin, the atypicals are gonna be like bupropion, mirtazapine, the tricyclics, which are really SNRIs, they're just the older form. And then the monoamine oxidase inhibitors, and so we're gonna go through each of those. So we've talked about using them, or making our choice based on safety and tolerability and side effect profile. So we're gonna start with the SSRI. So the products in this category are citalopram, escitalopram, which is actually the S enantiomer of citalopram. And you'll see this quite a bit where we'll get the active metabolite of the drug eventually as a single entity. Fluoxetine, paroxetine, and sertraline. So these are serotonin reuptake inhibitors. So remember where that occurs? So here's pre, and here's post-synaptic. Where are those reuptake receptors? Pre, okay. Okay, so transmission is coming down through that pre, and what's going to happen? What does that evoke?
Vesicles to go to the membrane.
So you get the vesicles moved to the membrane, and they release the neurotransmitters. Which ones are we mostly going to be dealing with? The serotonin and norepinephrine, right? Okay. So once they're released into the synaptic cleft, what do they do from there?
They bind to postsynaptic.
What?
Bind to postsynaptic receptors.
They bind to postsynaptic receptors, okay? And how do we terminate their activity there? CMOT and
MAO.
Oxidase, okay? And this. So those are the termination of activity, right? Okay, so our drug therapy is going to go after this, this, and this. Okay? Because we're going to try to increase the amount of time that serotonin stays available for action. So one of the things we're going to see with these drugs is that even though our main goal is a serotonin receptor or a change in serotonin, we've got histamine, we've got adrenergic, we have dopamine, we even have nicotine and acetylcholine. Oh, that's right. Often these drugs are not going to be pure agonists or antagonists. They will affect, often will affect other types of receptors or systems. One thing that will help you, I think, is when you're looking at the drugs and the side effect profile, is to consider, if I've listed that they're a histamine, that they can interact with histamine or muscarinic, what kind of side effects are you going to expect? If they interact with a histamine receptor, what's probably going to be a major side effect?
Inflammation.
Cholinergic.
Usually more drowsiness. What about muscarinic? Anticholinergic. What have I told you to remember? Slud, anti-slud. Okay. Adrenergic then can be on the cardiovascular system. Dopamine will have more psychic type of symptoms. nicotine, this one is a little bit lower. This one will have cholinergic type symptoms. Okay? So I'm just telling you that may start to help when we're looking at them. Okay. So the SSRIs have low affinities, so we don't tend to see these side effects as much with this class of drug. They all will decrease the action of that reuptake pump by about 60 to 80%. So they're fairly effective and powerful in their action. Reuptake, so kinetic differences. Let's talk about some of those. One big advantage in this class of drugs, if you're looking up there again at the products, is fluoxetine. All of these agents, with the exception of fluoxetine, have a half-life of about 24 hours, plus or minus a few hours. Fluoxetine has a very long duration of action. It's about, or half-life is about 7 days. So we can use that to our advantage when in patients who have adherence problems. I'll bring that back up again when we talk about withdrawal. Most of these drugs have some impact on 2D6 P450 isoenzyme. Fluoxetine and paroxetine are most potent. Now, the drugs that tend to be metabolized through that pathway are cardiovascular drugs. So there's not a lot of them. It's not a 3A4 system that we have to worry about, but it is with cardiovascular. So that's one to keep in mind. Here we have lots of variation. So choosing a drug based on its ability to avoid drug interactions may be a really important part. So fluoxetine, paroxetine, most potent inhibitors, sertraline to a less extent. Out of this class, paroxetine is a nonlinear kinetics. Remember what that means? What other drug did we run into recently that was nonlinear?
Phenytoin?
Phenytoin, right. So as the dose increases on the x-axis, on the y-axis you have response. So as the higher you go, then the greater the response you get for small changes in dose. So paroxetine, when we look at it, we have to limit how high we go with that dose. And when we get to the elderly, we find that they limit the dose in the elderly because as the higher you go, you get much more cardiovascular effects. QTc interval in particular with paroxetine. Citalopram and S-citalopram have very little impact on the P450 system, so it's one to kind of keep in mind, depending on the patient population you have. If you're dealing with a lot of young folks, it may not make so much difference. If you've got elderly or cardiovascular, then these become more important considerations. On the next page, there's a picture there to kind of help you. You see down at the very bottom of that slide, there is a psychopharmacology institute. That is an excellent site to go to, especially if you're really interested in psych. The materials that they put out are fantastic, and they're very geared for the practitioner. And they're geared for people who are, I think, more primary care. They're very good at explaining mechanisms of actions, updates. They're just, it's really a good link. Okay. So let's talk about the adverse drug reactions. Sexual dysfunction is going to be a problem with almost every class of drug that we're going to talk about. It affects women and men fairly equally. In this class of the SSRIs, paroxetine is the biggest offender. And you can see that the sexual dysfunction goes up to 80%. It can be a very common reason why people will stop the drug. For the rest of the class, it's a more moderate risk, but it's still fairly high compared to other drugs. The things that are reported the most are a decreased libido, difficulty achieving orgasm, and erectile dysfunction in men. So this would be one to talk to people about. Talk to them about ahead of time so that they'll know what to expect, but also to understand whether or not that will be a problem with them continuing therapy. The approach to treatment is to consider moving to a non-SSRI. We can use what we call the augmentation therapy, and we use bupropion the most. Bupropion seems to ameliorate the impact of the SSRIs on sexual function. So consider that, or switch to a different SSRI, try a different one. Or also you can use phosphodiesterase inhibitors, so like Viagra could be used as well, as long as there's no contraindications to it. Drowsiness is also a common complaint. I told you when you get above 5% side effects, we can start to consider that significant. So here you see it's about a 17%. This is a daytime drowsiness that people describe as having a malaise, so they just can't seem to get their energy up, their mental energy is diminished, or emotional blunting. So it seems like you're worsening the symptoms that you are trying to treat. So it can be a problem and one to watch for. Weight gain is common with all the classes of antidepressants. There is probably part that the drug is partly responsible. Some of it also is that as you relieve or the vegetative symptoms of depression go away, their appetite picks up. So often they will lose weight because they don't eat. They change their diet, appetite goes down. And so when you restore them and start to address some of those symptoms, then they eat better, and so their weight will go up. So weight gain probably comes from both of those, but it can be significant. Paroxetine, again, is one of the biggest offenders in this class, and you'll see that 1.6 to 3.6% increase in over baseline is pretty significant. So if they weighed 200 pounds, how much would they gain?
24 pounds?
So let's say it's about 4% of their body weight. What would that be? 8 pounds? Some people may not care, but it may be for some a significant change. The other worrisome, and we're going to see this when we talk on Thursday about the atypical antipsychotics, is that over time, long-term use of these drugs can lead to a twofold increase in the risk of diabetes. So monitor weight. If you have people who are already pre-diabetic, then watching and monitoring for their blood sugar more aggressively would be important. So CNS symptoms, we talked about the drowsiness. Some of these drugs are what we call activating. So they have a CNS stimulation or stimulant effect with them. And for those people, they tend to experience insomnia, so they can't sleep as well. The other thing that they have is anxiety. And this is a real problem. If you have people who have an anxiety disorder and depression, when you put them on some of these antidepressants, their anxiety will worsen. So addressing that at the same time as you start an SSRI will be important. And when we talk about anxiety, we'll talk about how to use some of the anti-anxiety agents along with the antidepressants to relieve that. So nervousness also can be a symptom they would complain about. It's usually transient, it will remit over time. So again, either treating that ahead of time or getting the patients prepared is another part. The other would be is to avoid fluoxetine if that's already an underlying problem. because that drug is the worst in this group for activation. Dizziness is another problem. These drugs tend to cause orthostatic hypotension. Paroxetine is the worst. All of them have modest effects, but that drug has the greater impact. And then headache, about 10%. So I've only addressed the side effects that are 10% above. So there's another whole host of things that can occur, but these are the most common. GI complaints, very, very common. So the SSRIs, there are serotonin receptors in your gut. And some of these drugs are not very specific. There are at least 5 different types of serotonin receptors. And so they are throughout the body. That's why you see lots of side effects in all different organ systems. So when you use this SSRI, you can see diarrhea as one of the very common complaint. The other is nausea. Luckily, it tends to go away over time, but in the first week, 1 to 2 weeks, it can be very significant. So paroxetine and sertraline, the highest with nausea, you see about 25% there with those. Diarrhea, sertraline, the greatest effect, highest reports of diarrhea. And then some patients get constipation, but diarrhea is probably the more common of the GI complaints. In terms of cardiac, the one drug to keep in mind is citalopram. It increases the QT interval. And it's more of a problem, it's certainly a problem in people who have underlying QT prolongation. If people are also taking other agents that prolong the QT interval, is problematic. It is so much so that it is recommended that that for patients 60 and over, the dose should not exceed 20 milligrams in a day. And for the younger, the dose is at 40 milligrams a day. This is an important one to remember, so please put a star out to the side of it. Citalopram is not recommended for patients who already have bradycardia, hypokalemia, hypomagnesemia, recent MI, or uncompensated heart failure. So what does that kind of remind you of, that cluster of symptoms we've just talked about? We talked about it in cardiology. When you have kind of those group of cardiovascular effects already in place, what are they most at risk for? Particularly with potassium and magnesium, we talked about it over and over again. Arrhythmias, but the more lethal type of arrhythmias, so the more malignant arrhythmias were higher incidence in those patients who had hypokalemia. So that drug has some of those underlying effects like you see with the 1C antiarrhythmic class. Hemostasis. So I would refer you to go back and look at the antiplatelet discussion we had in cardiology. Because do you remember, where does serotonin play a role with platelets? Do you remember? With clotting, yes.
I don't.
Okay, that's a good start. Can anybody build off what Mooney just said? So when platelets, what makes platelets bind together in the first place? Usually there's some break in the endothelium, right? So the platelets get attracted to that break in the endothelium. They bind there, and then the next thing they do is they have granules and they degranulate, and they release the contents of those granules, and what's in there is ADP, serotonin, thromboxane, epinephrine. And all of those are released in order to recruit more platelets to the area and to get them, do you remember they make those conformational changes from round to those weird little spiky projections so that they can adhere to one another and aggregate? Well, these drugs affect serotonin, and they sit on the receptors, and they don't allow serotonin to do its work. So you can see bleeding increased with people on SSRIs. It's more common in folks who are already on an anticoagulant. Okay? So folks who aren't taking that or are on a non-steroidal or anything else that would make them bleed, the risk is really low. But on anticoagulants, the risk goes up quite a bit. We'll see with venlafaxine with the SNRIs as well. Questions about those? Others, there's quite a few others: rash, itching, tremors, dry mouth. Paroxetine tends to affect the muscarinic receptors a little bit more than the others. Blurred vision. SIADH is the SSRIs are one of the drug-induced causes of SIADH. Okay, and then we've already addressed the Beers criteria. Okay, questions? Okay, all right, let's take a break and we will come back and start with the